we are able to, like I said, plan out the instrumentation to make dropping a rod down easier, and for deformity cases, kind of also factoring that into the plan as well of what it is that we eventually want to kind of achieve deformity-wise. So today, we're just going to go through the use of the robot to put screws in. I'm going to start off here showing you kind of some of the registration that's been done already. The workflow that we use is a preoperative CT workflow. So that means that we've taken the CT, we've taken a CT for the patient preoperatively. It's typically 1 millimeter thin cuts, and then that's uploaded to the robot. And then within the operation, we just take a couple of fluoro shots, just AP and lateral, and that's registered to the preoperative CT, and then you can run with that. There is the option, if you don't have pre-op CT imaging, to actually use an O-arm spin and use that intraoperatively as the pre-op CT, and then do the same thing. Or if you want to use fluoro, there's fluoro and so on. So we've acquired a CT here before. We've taken the fluoro shots, as you can see on the screen here. This is part of the registration. So centroids are placed on, for example, the vertebral bodies. And today we're going to demonstrate L3, 4, and 5. And once that's done, part of the registration and the verification happen, this is where the magic happens. The CT and the intraoperative fluoro are registered together by the robot. And then when that's done, and if it's in a good kind of algorithm, if it's achieved it well, you'll see these kind of images now. And to verify that the CT and the X-ray registered correctly, there is the option of literally looking at each end plate for each level that you did and making sure, for example, here at L4, I look at the superior end plate of L4, and between the X-ray, the intraoperative fluoro, and the CT, I see that they line up well. Same with a lateral and sagittal CT. That lines up really well. Yeah, absolutely. Yeah. Can you guys see that? Right. So I'm happy there. I check it for each vertebral body, L5. You can see that the CT and the fluoro match up pretty accurately. And it's got the outline of the screws that I've planned out preoperatively. And then as part of that, I want to kind of show you, we have the ability to sort of look at the screws that we plan out. So ahead of time, we plan out where we want to place the screws. And this is like a 3D view of it here. And for each level, for example, left L3, I have preoperatively planned to put that screw in. And let's say that that's the top screw of my construct. I want it to stay away from that superior facet. So if it's too high, like this, I'm able to make micro adjustments and then bring the head of the screw down. So in other words, I'm able to plan the screw such as it to benefit the goals that I have, which is to preserve the anatomy of the uninvolved levels, and then to go ahead and get me the exact kind of projection that I want. Also, the 3D view is nice because basically it lets me line up the screws here, and I can see where the heads are. Over here, I see that, for example, the right-sided L4 screw is a little bit off-kilter. It's offset with respect to where I want the other screw. So I can go to that screw, and then I can make kind of the adjustment. And I'm watching that screw head here and kind of adjusting it slightly. And there it is, and it comes better into view here. So that's kind of part of the functionality that this thing gives us. So once we're happy with the planning that we've done, then we're able to kind of proceed and then go on to navigate the screws for the patient. So okay, so we're ready. So should we start with kind of marking it out? The first thing that I do is that I mark out on the skin exactly where I want the incision to be. So we're going to do 3, 4, and 5, right? So I think if we go to L3, Just register that. Register, yep. L3, verify the level, and then go ahead, right? Yeah. Yep. There we go. Okay, awesome. So let's say I want to do L3, 4, and 5. So I want to start with the L3, left L3. I'm on the left side of the patient. So you do need to have good view or access between the radar. That's the reference, the dynamic reference space, or DRB, which is that reference frame. And the smaller marker is the surveillance marker there. And basically what it does is that between the camera and the reference frame, it triangulates, and some of the registration points on the end effector triangulates exactly where the screw will be placed. I like to kind of blow it up a little bit. I'm getting old like you, Rod, so I need maximum magnification so I can see everything. And so as a result, at this point, I'm able to just kind of drop down a marking pen here and mark out exactly where my entry point's going to be. And then I'll do the same thing for the next screw. You can see the little adjustments that it makes. Again, it's yellow means that you're on trajectory here. And once it turns green, it means that that's at the ideal depth for you to have placed your screw there. And the last one is 5. Again, L5, typically the marking point is slightly more lateral than where we want it. So I can see now that the marking points are going to be a little bit too lateral. So what I can do is go back to the plan, okay, and I can make that adjustment. It's just a little bit too lateral for me. So what I can do is kind of adjust the screw head and have it a little bit more medial. Of course, avoid kind of the getting into the joint as much as possible. But this is nice because it's able to position it for me such that my rod will be in a nice position because the screws are lined up. So once that's done, I'm able to go back to navigate and do the same thing again. There we go. And then if you watch this, this is the beauty of it. I'm able to make that adjustment here, and you can kind of see much better target there. So can drop the screw there. And then at this point, I'm happy. I have like my my entry points here. And I'm going to mark this out on the skin. Do a little marking here. Kind of mark out the skin incision. A little bit of space above and below where the entry points for the screws are. Sometimes I make it slightly more lateral because I know that they're medial to lateral pointing screws. Okay, take the knife at this point. Thanks. Occasionally what you can do is actually put, in a perk case, you can put the knife through the end effector. But in this case, I think what we're going to do is kind of just make this small opening here. Basically, I like to go down to the level of the fascia. And then once I'm in past the fascia a little bit, I have the option of kind of placing a finger there and coming on to the facet joint and sweeping a little bit of muscle off, particularly if it's kind of along the pathway that I know is my screw trajectory. So this is very nice. I can feel the facet joint. I've swept a little of the fibers off the facet joint, and I know that I'm going to be good with respect to my screw placement. Okay, great. So at this point, let's go back to the left L3 screw. At this point, I have green, so I know that the camera will be able to pick up the robot. Bring the robot a little bit more into the field there. So let's start with that left L3 screw. more into the field. And one other thing to notice for the first few cases is that you ask the staff and everybody to kind of step back a little bit, because remember, the triangulation depends on line of sight between the camera and the end effector. So I start with a high-speed burr, a 3mm high-speed burr. It's put straight down in through the soft tissue. I dock onto the bone. I can feel the bone there. You can see the trajectory there. Back off 1 millimeter, and that creates my pilot hole or entry point for the screw. Now, the other thing to notice is that this thing is keyed. So basically, the radar for your burr or whatever it is typically easily placed in a position where the camera picks it up. Thanks. I'll take the drill next. In between instruments, what I do is I just kind of press the foot pedal, and it makes that micro adjustment so that everything is accurate. Same thing, this is a 30mm drill for me. Again, I come straight down onto the bone, onto the entry point, back off 1 millimeter, and I'm able to drive it down. And it's typically to the end of the pedicle there. Place foot pedal again. And then you know that because there's green. The green tells you that you're on target. This is a tap. Now, typically, I don't tap for, you have the option of not tapping for a regular screw. I do tap for cortical screws where I want that kind of medial to lateral trajectory when I pass through the cortical side of the bone. And you can see here that it's nicely going through the pedicle. So once I'm passed through the pedicle, I'm done with the tap. And then we're ready for the screw. Again, button press, ensure our accuracy. And here we are. And literally in a matter of a few steps and a few seconds, you're able to pass the screw into the ideal position that you preoperatively selected. Now, you see that there's a check mark there. Well, that check mark tells me that I have attained the position that I previously planned for the screw, and I'm okay. Deliberately, I've driven it down very far here, and one technique is to not do that, is to back it out a little bit, because remember that the polyaxial head of the screw doesn't want to be in conflict with the facet joints or other kind of bony elements around. So, and then we can kind of remove the driver, and we're on to the next screw. I had to back the screw up a little bit for the exact same reason that I mentioned. So let's go on to L4 now. Again, kind of an ideal position with respect to where I've planned it. It's yellow, so it's on trajectory. At any point, I can stop, and I can kind of come in and out of that trajectory if I want. Like, for example, here, still on trajectory. And it should be going down. And redeselect, yeah. Try this again. There we go. And do it one more time. Yeah. And then back to this. There we go. It's obviously a very sophisticated piece of hardware, so it's highly sensitive to changes. And same thing again. Thanks. So again, back down with my burr to my ideal position. You can see it there, just on that superior articular facet. Back off 1 millimeter. There's my pilot hole. Button press again to ensure accuracy. Same with the drill. Coming down again. past the end of the pedicle. So again, you have the option of tapping. And I think, the companies come out with kind of new instrumentation all the time, and now they've come up with a screw which basically removes the need for the tap because of the specifics of the threads and so on. And then finally for the screw, again, simple kind of process. So for me, the greatest, and the other thing that we didn't talk about is the fact that all that radiation is removed. For example, from fluoroscopy, intraoperative fluoroscopy, especially for the surgeon. And so I have the check mark again. So this time, I'm a little wised up to it, and I kind of backed off a little bit there. So hopefully we can kind of remove that without incident. Finally, same thing with the final screw. You can see that it really maintains its trajectories, and it's able to make the slight angulations needed. So let's do something like, let's say that there was an Army-Navy here, and what we'd done is that we'd pulled on some aspect of the patient, and there was a slight change in here. And you can see kind of, there's a little bit of a Skive Meter through the surveillance marker. So let's say that I had changed something, and you can see that kind of, that marking there with surveillance, that things are moved, for example. If I'm ever in that situation because an Army-Navy's been put down or the patient has been worked on elsewhere and so on, literally I'm able to make that adjustment back to the correct position by, again, placing, readjusting, recalibrating by pressing the foot pedal again, and it gets me down to the kind of correct position. Like, for example, right now, let's say I move the patient slightly, and you can see how there's a skive there. So I put an Army-Navy down, and it's adjusted. I just press the button, and it makes that micro motion for me, micro adjustment for me, wherever I am. And of course, when we remove it, we're okay. We'll adjust again. So it's very, very accurate with respect to allowing you to make adjustments to the patient while you're working. And you get the drift again. Again, the steps are simple. Down, you can see we're down to the facet there. So burr, drill, again onto the bone. I get the green there, so I'm good. I'll back off a millimeter. On with the drill to the end. Tap. So particularly, like I was saying, that for the cortical screws, which are the medial to lateral, inferior to superior screws, these are very much things that I tap because I want to make sure that I am creating that trajectory, that ideal trajectory that I want. And it tells me that there's a deflection force there, so I can readjust things, especially when it comes to putting the screw in. And then finally, same thing with the screw itself. Again, we make that micro adjustment. Can make our incision a little bit longer. And look how easy it is. Even you could do it, Rod. This is this is really intended for all.
So are you using this for every case, or which?
So it's a good question. So we use this really for every case that we feel we want the accuracy. For example, if I'm doing an MIS case, I will use it. Now here the screw's not going down. That's good. I love troubleshooting. And I think it's because we didn't get the tap into the ideal position. So I'm going to re-tap. Let me take the drill again. I want to make sure that I'm going to extend the incision slightly. So, Rod, yeah, so for example, let's say that I'm doing a lateral at a single level, like an L4-5, and I want to fix it. So I either do a small kind of cortical small incision at the back. Let's say I want to kind of do my decompression. I can do that. Again, you see here that we're able to, there we are, we're green, so we know we're on target. There's my trajectory. I'm going to go straight to the screw. And then, or I just want to do perk screws. I mean, why spend all that radiation and time, X-ray and so on, when I can kind of use this? It's an intraoperative aid, basically, for me to achieve what I want with respect to the instrumentation. It kind of removes the instrumentation as a factor, in the case, Oh, we should have tapped, I think. So we're getting soft tissue binding there and so on. So we'll tap again. And this is good because, you can just clean that. Yeah. The other thing that it's very useful for me, some people use it for single position surgery, Rod, like you have the patient in the lateral decubitus position and you want to maintain that alignment. Mm-hmm. For us, we are really doing the prone, lateral and prone position. So that's what we found to be our workflow that we use. So it's still beneficial for us because we can put in the instrumentation while one surgeon is doing the instrumentation, the other surgeon is in the prone position, opening up the lateral incision and doing everything that they want to there. So again, we got green. It's good. Oh.
So Nooj, I talked to residents before you came, and they said that you're hogging
the what?
They said you're hogging the robot all the time.
Well, yeah, it's like I said, I learned a lot of things in my fellowship. One was to do that. So you get the drift, basically. So we're able to go down and get the instrumentation to where we want.
So how about let's say you're doing a prone lateral.
Yeah.
And you're having trouble putting that screw in, and do you check do you always check with fluoro at the very end?
Yeah, so that's what I like to do. So at the end, I bring in the fluoro, and we just check all the screws and see where they are. We may need to make, and I've never needed to make an adjustment to the screw once it's in. So I think that's the beauty of it. It really, you do the micro movement adjustments ahead of time. I'm sure that skiving is definitely a consideration here, and I think that that's why you need to burr. For me, doing a burr is part of the workflow for this, and that was the equivalent of the matchstick burr that you did. I think as part of prone lateral, the workflow for me is to put the instrumentation in first, and then go on and do my lateral work, because I then don't need to worry about things moving with respect to navigation and so on. But if you have if you do it intraoperatively, for example, you get an intraoperative CT once you have put in your lateral inner bodies, then it doesn't matter. You can, as long as you do the planning at that point. So I think it's just figuring out your workflow of what's most efficient for you. Dr. Kent and I were talking yesterday, and he incorporates an ALIF into it. So it's definitely an option, for example, to do the ALIF interbody first, and then do your registration, fluoro shots, line it up, match it up to the preoperative CT, and then go ahead, put instrumentation, put your screw instrumentation in L2 to 5, and then do the lateral interbody. So it's not difficult. You just need to kind of figure out the workflow that works for you. Good.
Great. Thank you so much.
All right. Very nice. Thank you.
Terrific.
Thanks.
Yeah.
Any questions about it all? The other thing that we've done, is that I've used the robot as a tool for getting to access points that I needed to. We had a case of Bertolotti syndrome where we had, an artificial fusion between the TPF5 and the sacral alar, and that was the pain generator. So normally that would have been a longer incision, even with O-arm navigation, trying to kind of work our way around the nerve root and that kind of thing. The beauty of the robot is that it tells me I can map out the trajectory that I want ahead of time, and the end effector will take me to the exact same spot that will get me to my target if you like, in a short distance as possible and avoid everything else. And then I'm able to, make my incision go straight down to it. And it just saves you muscle dissection. And of course, that helps the patient recover better. So for me, it's just been a wonderful tool. And it just, again, it removes the mental burden of the screw placement and the instrumentation. You still do the thinking about it, but it's off the field. It's preoperatively where you map out the screws, and you don't have the added stresses of what's going on in the OR at the same time as you're trying to, line everything up and put screws in and wonder if something's skived down, bring C-arm back in again and check it. It's just reduce the fiddle factor a lot.
So Noosh, a couple questions from the audience.
Yeah.
The first one is that, do you still use neuromonitoring, and do you see a role in potentially not using it? And then how about the cervical and thoracic spine? Are you using this in the cervical spine or thoracic spine?
Yeah, so that's a really good question. There is the ability to use it in the cervical spine. I'm always a little bit cautious because, the C-spine is a little bit more mobile, even if it's fixed between a Mayfield head frame and the chest. So for us, that is kind of the next step, if you like, is to use it. And I think in complex and challenging cervical cases, we definitely would consider it, just like I'd consider navigation with something like an O-arm. In terms of neuromonitoring, absolutely, for the thoracic cases, above the conus, I have neuromonitoring. For below the conus, in cases like a spondylolisthesis, where I really want to kind of do EMG on the L5 nerve root or other nerve roots, I definitely have that around. I think we've kind of got to the point where we use poor man's stimulation a little bit, particularly when we're doing screws, and I may pass a little current through the bovie, through the tower, particularly if the patient isn't paralyzed. But I think in routine cases below the conus, it's made a difference for me, and I'm much more confident with respect to not needing it. That's just a personal choice that we have made. I think if your workflow is to use neuromonitoring, at least for the first X number of cases till you gain confidence, you should continue with neuromonitoring. You can stim those screws, and you absolutely should. And once you gain the confidence, and you know the little nuances, like for example, where to place the reference frame, that it doesn't get in your way, and what a deflection is and what movement is, and so on. Then you make that step, you make that graduation.
Great. Thank you so much, Noosh.
All right, very good. Okay.